So now I'm going to focus on a very important part of this talk. And if you want to just take home one message from this whole talk, would be about stroke prevention. Because this is the worst thing that can happen to patients with atrial fibrillation. And not only is it bad for the patient in terms of quality of life and their survival, but it is also a significant healthcare burden for any healthcare system. So I think focusing on stroke prevention is the most important thing in patients with atrial fibrillation. So this slide just shows you the percentage of strokes that are associated with atrial fibrillation. So as you can see, as patients get older than 80 years old, about 20 to 30% of the strokes are caused by atrial fibrillation. It's a significant cause of strokes as patients get old. The risk factors for, so what you have to do is define the risk factors for stroke in these patients. So whenever I see a patient with atrial fibrillation, the first thing I do is look at what is the risk of this patient for having stroke. And the risk would include previous history of stroke, rheumatic heart disease, which if you still have it in your country, that is the most important. These are the most important risk factors for future stroke. If they have any of these, then there is no question the patients have to be on lifelong anticoagulation. The other risk factors include age more than 75, hypertension, diabetes, heart failure, ejection fraction less than 35%, hyperthyroidism, hypertrophic cardiomyopathy. Hyperthyroidism is an important thing. Whenever somebody is diagnosed with atrial fibrillation for the first time, you always got to rule out causes of atrial fibrillation that are reversible, and hyperthyroidism is one of them. So we always check thyroid function testing in patients to make sure that patients are not hyperthyroid, and that is not what is leading to atrial fibrillation. In fact, sometimes if they have hyperthyroidism, unless you treat that, you will not be able to control the rate, even in patients with atrial fibrillation. So this is a very important slide in terms of showing you the efficacy of anticoagulant therapy in preventing strokes in these patients. So this is a slide that included all these PAC trials. And what it is showing you is that if you give placebo versus warfarin, warfarin is an age-old anticoagulant drug that is available in every part of the world. If you give warfarin to these patients, you can decrease the stroke incidence from 4.5% annually to about 1% annually. This is a significant improvement. And it shows that the increase in bleeding is not that high. This is provided you keep warfarin in the therapeutic range, which is an INR between 2 and 3. Now, what are the newer forms of stroke prevention therapies available in these patients? So obviously there are procedures, which I'm sure will be limited in your part of the world, but there are other drugs that are available which are become better, which are not only better, I mean, they are better than warfarin. Again, it depends on availability of these drugs. These newer drugs are called novel anticoagulants or direct oral anticoagulants. And they have recently been available since 2010-11 and have been shown to be very effective in preventing strokes as good as warfarin. So the first one that was available was a drug called Dabigatran, which is known as Pradaxa over here. And I think that is the only form that is available. And this was a trial published in New England Journal that showed that there were two doses used. One was 110 milligrams and one was 150. The 150 milligram of Dabigatran was superior to warfarin in preventing strokes when these patients were followed about 2.5 years. The other drug that is approved is a drug called Rivaroxaban, which is again an oral anticoagulant. And it again showed that it was equivalent to warfarin in this trial, which is called the Rocket AF trial, in preventing strokes in the long run. And then the third drug that was approved is the drug called Apixaban, which was done. This is data from a trial called the Aristotle trial, where this drug showed actually improvement in mortality and stroke prevention as compared to warfarin over the follow-up period. So the question always becomes that these drugs are costly. They are brand drugs as opposed to warfarin, which is a generic drug. However, there have been a lot of cost-effective analysis, and they have shown that if you use these drugs, they are better than warfarin. This particular one was done using Dabigatran because that has been around the longest. But now we have cost-effectiveness done with all of these direct oral anticoagulants or NOACs, and they have shown that they are all better. The reason is that in warfarin, the levels are not very stable, and you have a lot of interaction. You have to change the dose back and forth. The patients have to have a blood test done. With these drugs, you don't need to do anything. You just give a dose of the drug based on the kidney function in most of the patients. And so in the long run, when you follow these patients, they are more, they give you more effective anticoagulation with less bleeding. Definitely less intracranial bleeding, which is one of the things that worry patients as well as doctors when they prescribe oral anticoagulants. So if you look at cost effectiveness, these drugs happen to be more cost effective than warfarin, even though they are more expensive to start off. Now, if the patients fail drug therapy or cannot take drug therapy because of bleeding risk, then you have to look at other ways to prevent stroke in these patients. And one of the ways to prevent stroke in these patients is to go after a structure in the left atrium, which is called the left atrial appendage. What this slide is showing you is that most of the clots that cause strokes in patients with atrial fibrillation, more than 90% of the time, these clots come from a structure called the left atrial appendage, which is a pouch-like structure in the left atrium, which is the left upper chamber of the heart. So if that is the case, and these patients cannot get drug therapy, or as it turns out, there were some trials done, if they want an alternative to drug therapy. Suppose you have a patient who is 50 years old, doesn't want to take an oral anticoagulant therapy for the rest of their life. Then you can devise some procedures to exclude the left atrial appendage to prevent stroke. So this slide shows you a list of different kinds of devices that you can use in these patients to prevent strokes. So if you look at this animation and the picture in the middle, this is the left atrium. In the left atrium, there is a structure called the left atrial appendage. This is the left atrial appendage. So either you can occlude the left atrial appendage by putting in a device called the Watchman device. There is another device called the amulet device, which is shown over here, or Coherex device, which are all devices that can be lodged in this structure, and then they can lead to closure by tissue overgrowth on top of this. Or you can use another method, which we've devised here, which is called the lariat method, where you go in and through a catheter maze method, you can tie off the neck of the appendage. So I'll just show you a little bit through pictures what we mean by doing these procedures. So the first one that was devised is called the Watchman device, which includes putting this kind of device in the left upper chamber, in the left atrial appendage. This is a TE picture of the left atrial appendage. Usually the left atrial appendage would have been empty here. Now you see it's been filled up with a device and the tissue has been sealed off. So this has been closed, and that will lead to prevention of stroke. This is a CT scan on the same patient, where you can see that that device has been lodged in the left atrial appendage. It has been endothelialized. So that left atrial appendage has been closed off by the device. The landmark study that was done with Watchman device is called the PROTECT AF trial, which was a randomized study comparing Watchman device to warfarin in patients who are eligible for anticoagulant therapy. This is the other technique of excluding the left atrial appendage. This is something that we started here at UCSF, and now it has been used all over mostly in most parts of the US as well as Europe. And it is shown to be an effective therapy. What this is doing is it is making something that the surgeons do. The surgeons can tie off the left atrial appendage, but they have to open the chest to do that. Here, what we do is through catheter-based methods, we can tie off the left atrial appendage by doing an endocardial and epicardial approach. As you can see here, you're injecting dye, the left atrial appendage is open. By the time you do this procedure, over here, the left atrial appendage has been closed. Now, when you inject dye, nothing is going into the left atrial appendage. This does require some expertise in doing it, because you have to be very good in doing dry epicardial puncture in these patients. But it is just showing you that through catheter-based methods, we can do this procedure, which was earlier only possible to be done by a surgeon by cutting open the chest. And again, this is an example of a patient who has a TEE done. So this is the left atrial appendage on the TEE. And after tying off, you can see that the left atrial appendage is now closed. Nothing is going down over here. So this is data showing closure rates of the left atrial appendage using different techniques. So this is the surgical technique, which is called the Atri clip, where they put a clip on top of the appendage. The closure rate is about 95% or more. With the Watchman, the closure rate was 86% in the PROTECT trial, but I think in the subsequent trial, their closure rate is also more than 90%. And the Lariat has not been done in that many patients, but the first paper that was published with it showed a closure rate of about 96%. However, if you look at numbers, probably you're going to find more patients with Watchman than with Atri clip than with the Lariat technique. This is the data from PROTECT AF, which showed that there is not only equivalency, but actually using the Watchman device causes better mortality and morbidity as compared to Warfarin. So this was a randomized study. And so this is a real landmark study showing that device therapy can prevent stroke in these patients. This is sort of a slide that has been made to not compare against each other, but sort of project it like that. So these are data available from the NOACs. NOACs were the Dabigatran, Rivaroxaban, and Apixaban, comparing those to Warfarin. And this is data comparing Watchman to Warfarin. So this just shows you that Watchman to Warfarin gives you a better efficacy in terms of mortality protection and reduction in strokes as compared to the oral anticoagulant drugs.